I'm Dr. Sarah Hallberg, Medical Director here at Virta, and I'll be your moderator today. For the health plan leaders, employer benefit leaders, and health systems leaders in the room, we have an exciting lineup for you. The Biden administration is facing a set of unprecedented healthcare challenges as COVID-19 rages on. Vulnerable populations, especially Medicare and Medicaid populations, have been disproportionately affected by the pandemic. Among them, those living with chronic conditions like diabetes face even more dire circumstances. What policies will turn this trend around? And how should health plans, employers, and health systems prepare? Few people are better positioned to share these insights than Don Berwick. Dr. Berwick was previously the head of the Centers for Medicare and Medicaid Services, nominated by President Barack Obama, and CEO of the Institute for Healthcare Improvement. Over the course of his career, he pioneered several bold initiatives to transform healthcare, including the 100,000 Lives campaign and the 5 Million Lives campaign. We are so very lucky to have him here with us today. And first, I'll hand it off to Dr. Berwick. Welcome, Don. We're again delighted to have you.
Thank you. Well, it's a delight to get to share some thoughts with my colleagues at Virta and with the many of you that have joined this webinar. I should begin with a bit of a disclaimer. I don't have an absolute clear crystal ball about this. I'm not inside the Biden administration, and I'm really an observer of it. And so a lot of what I'll try to share is speculative, admittedly, building on my experience during the campaign when I served on the Biden-Sanders Unity Task Force for Health, which I'll explain in a couple minutes. So I'm going to quickly walk through some of the contextual factors that I think are setting the stage for what will emerge as the health policies in the Biden administration. Then we'll read that into the diabetes world. COVID is dominant now, 24/7. I'm sure this administration is focusing its energies on stopping this dreadful, tragic pandemic and doing it, I think, increasingly well. We now see mobilization of science and logistics and commitment to values that I think will inform a much better response to the COVID pandemic in the US than we've seen so far. As you know, we're among the 3 worst performing countries in the world, as measured by the number of deaths we've had and the burden of the pandemic. The pandemic is going to leave us with a changed healthcare landscape, and I'm going to begin there because I do think this will be factored into any policy discussions in the future. COVID has brought us speed of change that we've never seen before. There's a lot of adaptation going on in healthcare right now, and I don't think that's going to stop. Our accommodation to virtual care, for example, is only one of the visible ones. We have new learning processes underway. The United States is part of a global learning endeavor around the pandemic, and we're seeing information speed around the world in a way that I find quite thrilling. President Biden's intention to have us rejoin and enthusiastically the work of the World Health Organization and the global medical environment is only one of the examples of that kind of investment in speed of learning and change. We've also increased the stakes on evidence-based care in this country. There's been a longstanding debate between the problem of achieving evidence-based care, committing ourselves to honoring science and care, and the understandable request and demand of the healthcare clinicians to have clinician autonomy. Right now, we're seeing a sea change. Clinicians all over the world and all over the United States are hungry for information about the best known ways to take care of COVID. If we generalize that and become even hungrier about the best known ways to care for any condition, that will be a tectonic change in our overall approach to standards in medicine, a very favorable one. You all know about virtual care. It's soared in COVID. I spoke with a community health center director that went from 5% to 95% virtual care in a week. And this is forcing us to reconsider some time-honored assumptions about visits and proximity. Virta, as you know, does a lot through the virtual world. And I think it's very much a modern participant now, but will be an increasing array of opportunities that people have to get their care virtually. I myself had 3 medical encounters in the past 2 months. I'm just fine, but I needed care. I got it virtually, and I would call it perfect. Immediately accessible. I burned no gasoline. It saved my time and the clinician's time. Protecting the workforce is obviously a very important moral, logistic, and political issue. We dropped the ball in COVID, and I don't think we can't let that happen again. And so whole new views of how to get the healthcare workforce the protections and the supports it needs, with an expanded view of the workforce to include far more than doctors and nurses, but now to all of those whose combined efforts help us deliver the care we need. We have a whole new agenda ahead for preparedness. We thought we were prepared, at least that's how we were rated in international indices, but we weren't. And you're going to see a surge of new interest in understanding what a truly strong public health system looks like, including one prepared for 21st century threats. And then probably the biggest theme of all, and one that we're seeing already manifest in the Biden work that's gone on since the election, as well as during the campaign, is a deep, deep investment that this country can and should make in resolution of inequities in health and health status. The inequities are very deep, and I'm going to spend a minute with that. We have a very strong problem, a big problem in this country when we seek health related to social determinants of health. That is, the well-being of the public with respect to health is not about health care. It's about the pursuit of health and the so-called social determinants, the conditions that produce health and wellness. We know what those conditions are, by the way. They're very well documented. The conditions of early childhood experiences, the strength of education systems, the strength of workplaces, minimum wage structures suitable for a full life, attention to the needs of elders, especially around loneliness and isolation, strong community infrastructures like food security and housing security and transportation and recreational opportunities, a sound criminal justice system that's really restorative. These are the factors that make us well or ill. And in our society, in the United States, we're not doing well. This is one manifestation of the inequity. This is the expected age of death for a person in the United States who reaches the age of 40. On the vertical axis, on the horizontal axis is household income. Notice that at the bottom levels of income in our country, life expectancy for men and women is 10 to 15 years shorter than for people at the top level of income. And that is a continuous relationship over the entire spectrum of income. We have high levels of inequity and outcomes related to income and wealth. That is a function of social determinants of health and public policy. It's not inevitable. The consequences for people in our country are quite dire. You all know that for 3 years running, 2014 through 2017, for the first time in recorded history, life expectancy in the United States fell, did not rise. It then leveled off for 2 years, and now this year it fell again in the COVID pandemic. 1 year of life expectancy loss for white Americans, 2 years of life expectancy loss for African Americans. Part of that is due to what are known now as deaths of despair, so categorized and analyzed by the Nobel Prize winner, Professor Angus Deaton and his partner Ann Case, who have been writing about the burden of illness, injury, and death that comes from inadequate social conditions in our population, especially affecting people in their middle ages, reflected in substance misuse deaths, alcohol-related deaths, suicide deaths, what they call deaths of despair. So when we think about health policy in the United States, this one big theme of equity, social justice, and closing equity gaps is, I think, a big deal. And it is in the Biden camp. I know that from our work with the Biden-Sanders Unity Task Force. Now, that Unity Task Force existed during a mid-stage of the campaign when Joe Biden sealed up the nomination. He and Bernie Sanders agreed to establish 6 Unity Task Forces, 3 members of each task force appointed by Sanders, 5 by then candidate Biden. I was a Sanders appointee to the Biden-Sanders Unity Task Force on health. There were task forces on immigration, task forces on criminal justice, on environment, on education, and on the economy. So I'll give you a quick overview because this was the resolution of a conversation about in the platform period, not post-election, about where this administration might head. There were elements related to COVID-19 and public health in general, of course, a whole bunch of efforts around expansion of coverage. As you know, we're the only Western democracy in which healthcare is not a human right. We leave out 30 million people and more millions during the Trump administration's period in office. Biden committed and the task force supported methodologies to increase coverage. A lot of work on prescription drugs. The prescription drug cost problem is severe and it comes right out of the pockets of beneficiaries, not just the government. Long-term support services, long-term care and support services, delivery system change, and improving equity were other themes. I'll show you quickly some of these. Now, I know this is fine print. You'll get these slides, access to them if you want. With respect to public health, there was a very serious intention during the campaign to reinvest in a strong public health system and to emergency supports during the pandemic period that would really get the backs of people who are losing jobs, losing healthcare, and placed at financial risk. In particular, offering new forms of coverage, a zero deductible option in the marketplace. There was the proposal to move toward a public option. We'll talk more about that in a minute. Expansion of COBRA coverage in time and subsidy levels, and overall trying to trigger in the pandemic era much more of a safety net for people who are otherwise losing security. In the coverage arena, these were the commitments that the Biden-Sanders task force urged on the campaign to expand Medicaid and Medicare enrollment to age 50 as an option, to add vision, dental, and hearing benefits to Medicare, or at least take a look at that, and to create a greater, more generous subsidy situation for people who are using the exchanges. As of the current law, at 400% of federal poverty, there's a cliff. You get no more subsidies for getting insurance. The proposal from the task force, triggered by candidate Biden, was that no one should spend more than 8.5% of their income on premiums in the exchanges. And that indeed is the policy that they've now carried forward with. There was a proposal to establish a public option. This would be a government option, so people could essentially buy into something like Medicare, a government insurance plan. This is a much more politically difficult task. It's one way to expand coverage. It is still being talked about. It is not yet in policy in the Biden administration. They're choosing other ways at the moment to expand coverage, but this definitely was coming out of the task force consideration. That's going to be a subject of debate in the next year or two, I'm sure. One of the big questions will be, will the public option be essentially private? That is an expansion of Medicare Advantage, or will it be indeed a government insurance program that's optional for people if they want it? There was work on reducing out-of-pocket drug spending burdens on beneficiaries, which have gone up quite a bit. In the arena of they should say public option, not public opinion. The public option was proposed to be a planned choice offered by the government without deductibles to be administered through the traditional Medicare program. That was the Biden-Sanders Unity Task Force proposal. That is a politically difficult hurdle, as I've said, because it threatens the private insurance system, which would rather be the purveyor of insurance in this country, of course, and have great lobbying energies. Medicaid was seriously damaged in the Trump administration. There were still 12 states that have not expanded, and a lot of waivers and sub-regulatory guidance was offered that increased difficulties for Medicaid enrollees to get re-enrolled, to stay eligible. Work requirements were threatened, and tens of thousands of people lost Medicaid coverage even under the threat of work requirements. The public charge rule was called into play. That's a rule that says that for people who come in who are legal immigrants in the country, it limits their ability to get access to Medicaid as a support. And as I say, 12 states have still not expanded. And in the Biden-Sanders task force, all of these efforts to get Medicaid back into a very healthy shape were put forward by the task force. And indeed, we're seeing action in the Biden administration to repair some of the damage to Medicaid that is underway. 12 states still have not expanded. I believe Kansas, just 2 days ago, legislature again voted not to expand. This is very unfortunate choice, leaving a lot of people high and dry and leaving a lot of money on the table for states. And I think we'll continue to see that play out. The arena of prescription drugs is very fraught, full of lobbying intention. HR 3 was the bill passed in the last Congress that was a drug reform bill with a lot of potential for reducing costs and increasing coverage of drugs. There is in the Biden-Sanders task force, a lot of ideas were put on the table to reduce the cost of prescription drugs through reference pricing to European markets, through the ability of Medicare to negotiate drug prices. Medicare cannot negotiate drug prices, even though it's the largest, I believe, the largest purchaser of medications in the country, and to deal with some of the antitrust issues that could be addressed through reforms in patent law and some of the pricing behaviors that we're seeing in both generic and biologic markets. There is a great deal of interest in the Biden camp on improving long-term care supports. I know from reports that President Biden cares deeply about the nursing home and long-term care world. And there are strong endeavors now to increase the workforce that helps in long-term care, both home-based and institutionally based, increasing the well-being of the workforce in long-term care so they're fit and ready to help these people who are aging and suffering. And there's a whole bunch of work that you'll be seeing on delivery system improvement. This is my wheelhouse, trying to help improve delivery directly through expansion, for example, of federally qualified community health centers, perhaps expansion of the National Health Service Corps, and a strong emphasis on improving the status of rural health through rural health demonstration projects and global budgeting systems for rural health, I hope. Equity was by far the loudest and most persistent theme in the Biden-Sanders Unity Task Force work, and you've heard it over and over again from this administration. You just look at who Biden has already appointed in the health world and elsewhere. You're seeing a strong, strong emphasis on closing the enormous gaps in equity like the ones I showed you at the beginning of this presentation. I believe that is real. The language used in the task force that I think will be the language I hope will emerge in the Biden camp as president is all of government approaches to deal with the social determinants of health. That cannot be done through a single government agency. It's not a one agency issue. It's not just HHS. Agriculture is involved. Housing is involved. Transportation should be involved. The Veterans Administration and so on. And in fact, it's hard to imagine a federal agency that won't be involved in a full bore effort to improve the social determinants of health and wellness. We're seeing that happen. If you look at the detailed content of the $1.9 trillion rescue package that's now been passed, you will see a tremendous amount of very sophisticated policy helping to mitigate some of the burdens that are being faced by people in the levels of disadvantage in the country. Some of this can be done without legislation, and that's what you're seeing right now, of course, or through reconciliation, which is what's possible now with a 50-50 Congress. Some have to do with executive orders, and there's a great deal of effort underway now to reverse some of the negative executive orders from the Trump administration, but also to craft some good ones coming out of the Biden administration. I have a particular interest in the Indian Health Service, very relevant to diabetes, and I sense in this administration a real commitment to helping Alaska Natives and American Indian communities. The lens to use as you watch what Biden does are these four questions, which is, will this progress us toward healthcare as a human right? We're seeing more and more energies toward seeing that those 30 million people find coverage. Will it improve the quality of care? The Centers for Medicare and Medicaid Innovation have tremendous latitude to work on quality, including for chronic diseases like diabetes. Will it improve the social determinants of health in that equity theme I've talked about? And will there be significant efforts to reduce costs by reducing waste and by reducing pricing that does not make sense, especially in the arena of pharmaceuticals, but also with market consolidation of hospitals in many markets around the country? Everything will be toned right now through the theme of COVID-19 and the pandemic, and through the still persistent and hopefully never-ending concern about structural racism boosted by the murder of George Floyd and Breonna Taylor's death and others, but still as a pervasive sense that structural racism is a serious issue. It underlies a lot of the inequities you talked about, and I believe you'll see this president work on that. For diabetes care, what does this mean? I don't know. I would say these are a number of things I might predict. You will see equity everywhere, and to the extent that diabetes has elements related to racial and socioeconomic equity, I would expect to be fully part of the attempt of this administration to make us a much fairer, juster, and more equitable country. I do think you'll see continuing movement away from fee-for-service payments. All the policy analysts I know think that value-based payments and global budgets will be a positive theme. Again, in diabetes care, this would be reflected in much more flexibility in how funds are used to reverse or treat diabetes away from just widget by widget payment. I do think there'll be strong efforts to continue to expand Medicaid, trying to woo those 12 states into reconsidering what is currently, in my opinion, a very unwise policy not to expand. The workforce is an object of enormous attention in this administration. Fairness in the workforce, improving the economic conditions of people at the lower end of incomes in the workforce, and supporting expanded approaches to scopes of practice, I hope. Virtual care will be well supported. This could be bipartisan, and I think we're going to see any organization that is getting sophisticated about non-visit based care will have a favorable road in the Biden administration. I certainly hope so. Prices in healthcare are far too high, and there will be, wherever possible, pressure back on prices that have been raised by consolidated hospital markets, by monopoly behaviors among drug manufacturers and others. And you'll see policies develop in that. Biden has repeatedly expressed his support for federally qualified health centers in one way or another. I think you'll see expanded support there. And as I say, I think Indian health will be a theme, not an enormous one, but a very, very important one. That's my bet about where we're headed. I welcome listening to my colleagues on the panel and to the dialogue with those of you attending this session. Thank you very much for the chance to share these thoughts, Sarah.
Thank you so much, Don. That was fantastic. Our second panelist is Dr. Robert Ratner, who is currently the Chief Medical Officer at Virta Health. Dr. Ratner is also a professor of medicine at Georgetown University Medical School in Washington, D.C. After 35 years of active patient care and clinical research in diabetes, he served for 5 years as the Chief Scientific and Medical Officer at the American Diabetes Association. Thank you so much for being here with us today, Dr. Ratner. Over to you.
Thank you, Sarah. It's a pleasure to join you today. In 1994, I had the great honor of being part of the steering committee and planning committee for a major NIH trial that ultimately was called the Diabetes Prevention Program. We had two critical questions that we were addressing. Number one, can we identify individuals who are at risk for developing diabetes? And number two, can we intervene to prevent that progression? As many of you may know, in 2002, we presented the findings from a randomized controlled trial of close to 4,000 patients with prediabetes, showing that number one, we can identify people at high risk. The placebo group progressed from prediabetes to diabetes at a rate of 11% per year. Metformin was the one drug that was followed throughout, reduced the risk of diabetes by 31%. But a lifestyle intervention was able to reduce the development of diabetes by 58%. Thus, what we were able to say was we can identify people at risk and there's something that we can do for them. Now, because of these findings, we had to unblind the study and we needed to be able to provide some therapy for the placebo group. But the group has been followed continuously since 1996. And in 2013, we presented the 15-year outcomes. Now, keep in mind that the placebo group were now receiving a lifestyle intervention. The lifestyle group actually had a diminution in the intensity of their therapy. But even after 15 years, what you see is that lifestyle has a greater effect than medication. And clearly there's a sustained benefit in terms of reduction of the development of glucose. Now, keep in mind that glucose is a continuous variable. We categorize diabetes and prediabetes from normal based on cutoffs, so that when you look at prediabetes, those individuals who have fastings between 100 and 125 or 2-hour post-glucose load values between 140 and 200, they can go in one of two directions. They can proceed to develop diabetes by crossing the threshold, or they can regress to normal. One of the aspects that we looked at in the diabetes prevention program was, given this large population who all presented with prediabetes, what's the impact of actually normalizing glucose? And what you can see here is that regardless of the group that an individual was randomized to, if at any point in time in the study, they actually had normal glucose levels by glucose tolerance testing, what they actually did was reduce the overall rate of progression to diabetes by 56%, independent of what the intervention was. So there's value not only in preventing progression to diabetes, but there's clearly value in normalizing glucose levels. Now, one of the major questions then was, how do we take this massive NIH study and translate it into the community? And my colleagues at Indiana University, Ron Ackerman and David Marrero, said, let's see if we can put it into the community through YMCAs. The idea was that most people live within travel distance to a Y, and this is a place where the community can actually get involved. The Deploy study utilized the Ys, used a lifestyle intervention similar to the DPP, and achieved a 6% weight loss in 6 months. This was the study that drove the CDC to develop their national diabetes prevention program. One registered with the CDC in order to deliver the program. They had to meet certain criteria, and then it was rolled out to the community. And in fact, in 2016, CMS, Centers for Medicare and Medicaid Services, approved reimbursement for these community programs delivering the National Diabetes Prevention Program. This was the goal, to try and translate the findings. Well, what have been the results? Recently, a nationwide publication on the National Diabetes Prevention Program revealed that it's really quite challenging. Only 32% of individuals remained involved at 10 months. The degree of weight loss never met the goal, and it was clearly related to how long the patient stayed in the study. So that became a real problem. And in an editorial in the December issue of Diabetes Care, Professor Ritchie from the University of Colorado said we need to be looking for alternative approaches. Well, it turns out that our moderator, Dr. Hallberg, had been thinking about this years before, and in fact had recruited a group of individuals with pre-diabetes into her Indiana University study and followed them for 2 years to look at the level of progression. This has now resulted in a peer-reviewed publication that just recently came out with Sarah as the senior author. And we can make this publication available to any and all of you who wish. What were the findings? First of all, 75% of participants were retained at the 2-year period. Keep in mind, NDPP only had a third of patients at 10 months. Not only that, what we saw was a very slow progression to type 2 diabetes. Over 2 years, only 3% progressed. But we had 52% who regressed to below prediabetes ranges and were off of metformin therapy. Clearly a significant benefit. How do we put this into the framework of the NIH DPP and the CDC NDPP? Well, you can see that our regression to normal was considerably higher than was seen in the NIH study. And our prevention of progression was greater than what was seen in the NIH study. When you begin to look at overall impact, what really is driving all of this is the change in weight. So you see the baseline distribution of BMIs within this study, and it pretty much looks like a prediabetes population with predominantly class 2 and class 3 levels of obesity. Over time, what you see is this leftward shift in BMI as the entire population begins to lower their weight. And so you see a population benefit here in terms of the BMI. If we put that into perspective of degrees of weight loss that were seen in a whole variety of different diabetes prevention studies, you can see that Virta in this deep blue line has both the greatest degree of weight loss and a persistence in weight loss. This little orange line is the 6-month data from the National Diabetes Prevention Program. And green is what was demonstrated in the NIH lifestyle program. So clearly weight is driving much of this difference. But in fact, we're not just impacting weight. Clearly weight goes down, clearly glucose goes down, A1C goes down. But what we also see is a fall in blood pressure, a significant fall in triglycerides, an increase in HDL cholesterol, and a marked improvement in liver function. Now, these are continuous variables that were measured at enrollment and at 2 years. What about putting it all together into a clinical diagnosis? Well, virtually everyone who came into this study had metabolic syndrome. At 2 years, we had reduced that almost by half. Most were moderate to severe obesity. That was reduced by 1/3. And fatty liver disease was reduced almost by 1/2. Now, these are all markers of disease as opposed to hard outcomes. Keep in mind, this was a pilot study. It was only 2 years in 90 patients. What does it take to show hard outcomes? Well, the NIH Diabetes Prevention Program followed patients out to 15 years with over 3,000 patients and demonstrated an impact on microvascular outcomes, the composite of nephropathy, neuropathy, and retinopathy with a threshold level of 6.2. Well, 6.2 is less than the diabetes threshold, but it's within the prediabetes threshold. And what you see is a continuous fall in the risk of microvascular disease as you get individuals to normal. What about macrovascular disease? This paper came out in January. It's looking at 14,000 individuals with prediabetes who were followed for 10 years, with the outcome being cardiovascular outcomes, whether it's total cardiovascular disease, myocardial infarction, stroke, or all-cause mortality. What you see is the blue line are those individuals who progressed from prediabetes to diabetes. The green line are those individuals who remained at prediabetes. But the red line shows those who regressed to normal. So by taking individuals from prediabetes to normal, you're getting an even bigger bang for your buck in terms of risk of cardiovascular disease. You clearly have a benefit if you can prevent them from going to diabetes, but normalization is even more important. So what can we say? Diabetes prevention reduces microvascular disease. It reduces cardiovascular risk factors. It reduces surrogates of atherosclerosis, And now we can even show that it reduces cardiovascular events. And the simple fact is, from a societal standpoint, we have to prevent diabetes or our health system will be consumed by it. Thank you very much for your attention.
Thank you so much, Dr. Ratner. Up next, we have Sami Ikonen, CEO and co-founder of Virta Health, sharing more about the opportunity for diabetes reversal for Medicare and Medicaid patients living with diabetes. Sami, over to you.
Well, thank you so much, Dr. Halbrook, for that kind introduction. And then also thank you to Dr. Berwick and Dr. Ratner for your sections. You two you three were the real stars of today's webinar. But I'll finish off by sharing a few things about what we do at Virta Health. So as Dr. Ratner mentioned, we absolutely have to and should and want to prevent type 2 diabetes from happening. So we should absolutely address pre-diabetes and prevent type 2 diabetes from happening. However, unfortunately, we already have more than 30 million Americans living with type 2 diabetes. And the cost of diabetes in America is really mind-blowingly high. It's $400 billion a year. And those of you who are more sort of financially inclined, that's $400 billion a year is more than the combined global market that Google and Facebook are going after. So one disease, one country, sadly costing more than the global online advertising market. So we want to prevent type 2 diabetes from happening. But what do we do with this problem when we already have this kind of an epidemic with type 2 diabetes today? Well, we like to ask this question at Virta Health. What if there was a treatment that could actually reverse type 2 diabetes systematically and consequently eliminate the need for costly medications such as insulin and save thousands of dollars per patient per year? Well, somewhat self-servingly, we ask this question because this is exactly what we do every day at Virta Health. So we reverse type 2 diabetes. And we intend to do this for millions and millions of people, given our mission of reversing type 2 diabetes in 100 million people. So when I say we do this every day, so what are these results? So compared to perhaps the more traditional approach to this chronic disease, type 2 diabetes, where we prescribe medications to treat the symptom of type 2 diabetes, that is high blood sugar. When we compare the Virta treatment to any of these widely prescribed medications, you can see here on this slide that we deliver similar or better glycemic control in terms of low A1C. Additionally, very substantial weight loss, 12% on average at year one. And then, of course, in the case of Virta, we don't add or prescribe more diabetes medications, but save thousands of dollars per year or hundreds of dollars per month per patient because we can eliminate the need for medications. So compared to any of the traditional approaches of just treating symptoms with medications, our results in type 2 diabetes reversal are transformative. And of course, as a disclaimer, I should say, these are results from different studies. So this wasn't a multi-arm study, one single study. So just that as a disclaimer, but these are the typical results we see. Of course, those are just numbers. What are the numbers that patients see? But one of my favorite examples to show what happens or how patients feel about the experience of reversing their type 2 diabetes is this. And you may wonder, what is that photo on the right? Well, turns out it's one of the Virta patients who decided to take the company logo as a permanent tattoo on her body after we reversed her type 2 diabetes. Now, not something that I would be promoting or recommending, but it just goes to show that the quality of life improvement is quite transformative if you can take a chronic progressive disease such as type 2 diabetes and literally reverse it in a matter of months. Well, a good question to ask here is how generalizable are those results that Verda has seen in our clinical trial and some of the patients that I mentioned. And we have to prove that every day. And one way to make a case that they are quite generalizable is, here's a sample of different employers that we've worked with. There's blue collar, white collar, concentrated workforce in one office building, distributed like US Foods, truck drivers, and even the US Veterans Administration. And without going through all these numbers, you can see there that the glycemic control is roughly the same, the first line across different populations. We see similar type of elimination of diabetes medications at 1 year. The majority of diabetes medications eliminated. And the same with weight loss. So we've seen more or less any kind of a population in America that you can imagine and have been able to show that the results that we delivered in our prospective clinical trial with the Indiana University of Health have now been replicated, not just in these 7 populations mentioned on this slide, but now literally in hundreds of different large employer health plan populations. Equally important and very relevant for this presentation, as we heard from Dr. Berwick around impacting Medicare and Medicaid populations, we've seen similar type of results across the elderly population, 65 and older, lower income, that includes both Medicaid populations and some of our Native American tribe partners. Same kind of results in glycemic control improvement, elimination of medications, and weight loss. But again, as a provider, we have to prove these results every day, so we don't just stand behind 1 or 2 clinical trials, but we have to prove these results every single day, which we've now done on a population level across many, many different populations. And then, of course, this question comes up, you know, these are people, you're treating people, type 2 diabetes, reversing type 2 diabetes. How about the other 3 or 4 chronic comorbidities? And what we've seen is that, interestingly, or perhaps unsurprisingly, when you address or improve or reverse type 2 diabetes and obesity, what tends to happen is the other chronic comorbidities improve or get reversed as well. And what you see here on this slide is the similar data that Dr. Ratner was showing, in that when we reverse diabetes and patients lose substantial amount of body weight, you see marked improvement in inflammation markers, cardiovascular disease markers, liver enzymes, as well as inflammation. And then in terms of whole patient care, Verta, as a licensed provider in all 50 states, obviously, when we take a patient, we take a patient. We don't just throw a protocol or app that addresses a single symptom, such as high blood pressure. Every time we treat a patient, we look at the entire situation with that specific patient. So reversing type 2 diabetes is truly whole patient care, not just addressing one symptom. How do we do this? I'm going to be very brief here. There's 2 elements to be able to deliver the kind of results that we've seen. One is we address the underlying drivers of obesity and type 2 diabetes through nutrition. But it all happens through behavior change, so we don't deliver anything or any food products or sell food products. So it's all through behavior change, and in a highly individualized fashion. Literally, we individualize the experience and recommendations to the N=1 patient, which is necessary. And Dr. Berwick mentioned social determinants of health. We have to factor in all the things around the person to be able to make it effective. And then secondly, the best protocol does not work. The best protocol does not work unless people have the support and they can adhere to. And at Verta, we deliver all this support through telemedicine. But most importantly, it is very intensive, daily, continuous support. It is not episodic 3 times a year or 3 times a week. To give a sense of intensity, we interface with most of our patients 2 to 3 times per day, 2 to 3 times per day. And we can do that in a very individualized way. by remotely monitoring the biomarkers of our patients. So those are the two elements that are needed to deliver type 2 diabetes reversal, even in late stage type 2 diabetes. And with these two capabilities, our initial focus, which is what I've been talking about here, was really to focus on perhaps the most difficult part of the obesity diabetes spectrum. That is people with type 2 diabetes, in most cases, people who are on many diabetes medications. So our focus was on reversing type 2 diabetes in this group of late stage individuals with type 2 diabetes. Now, over the last year or so, many of the large employers and some health plans that we work with came to us and said, well, obesity, prediabetes, diabetes is really just the spectrum. And now that you built these capabilities to address the underlying cause and provide telemedicine-based support, could you help the entire population? Could you help the entire population depending on their readiness to change? And our answer, which we publicly announced a few months ago, was absolutely, we'd love to. We'd love to help as many people as possible. So today, Virta does not only reverse type 2 diabetes, but we support and address everyone living with type 2 diabetes, as well as people with just prediabetes. And I'm going to finish it off here and encourage all the listeners to ask questions. I think Dr. Hallberg will moderate a Q&A session here for the next 15 or 20 minutes. So please keep posting questions, and then we'll pick some. And again, thank you everyone for tuning in.
Thank you so much, Sami. If I could have the the panelists all return, we're going to start with some questions from the audience. So I'm going to start with this one for you, Don. How will new price transparency requirements for U.S. hospitals and health systems impact chronic care for patients?
Prices in American healthcare are rather opaque. It's very hard to find out who's paying what to whom. I tend to believe that as transparency increases, purchasing can get smarter. If we can compare transparency of pricing with, combine it with good information on outcomes and quality, then healthcare can be much more of a smart purchasing environment. For people with chronic illness, they're the ones that are paying the most. They're paying the most out of pocket. Their costs are higher, and therefore the benefits to them of actually having a healthcare ecosystem in which we actually know where the money's flowing should be much, much higher. One experience I had with that when I was running Medicare and Medicaid, we introduced a bidding structure for durable medical equipment and ostomy supplies. We just allowed bidding to occur, and cost fell by $28 billion in that trial, with higher quality of products. So I'm in favor of price transparency, and I think it will help people with chronic illness.
Great, thank you. This next question is actually for both Don and Bob. The U.S. Preventative Task Force has consistently chosen not to screen early onset of prediabetes and diabetes because it makes no difference in cost, morbidity, mortality within our current orthodox treatment of diabetes. What might the U.S. Preventative Task Force or the government do to change this abysmal situation?
I could start, Bob. I was the vice chair of the U.S. Preventive Services Task Force for 5 years, and I understand it well. It's an extraordinary undertaking. It's an attempt to link policy to evidence by having an objective group of scientists look at data and then score the certainty with which clinical preventive practices are supported by the information. And so the answer to the question is that the U.S. Preventive Services Task Force will look more favorably on these kind of interventions as the evidence grows and becomes more certain, which is exactly the discipline we should want. Virta should and does welcome the development of the evidence base. The other good news is that under the Affordable Care Act, something extraordinary happened. Medicare was not set up originally as a preventive services. In fact, it was a hospital coverage system. And the Affordable Care Act changed that. In the Affordable Care Act, by statute now, any clinical preventive practice that is graded A or B in evidence, that is either certain or was very strong evidence or strong evidence, has to be covered by Medicare with first dollar coverage. Tens of millions of people then get first dollar access to known effective clinical preventive practices. So we have the policy environment, and now the job is to accumulate the evidence that meets the standards. And that's exactly what I think we should be doing.
And in fact, that's what happened. So initially, diabetes prevention was not scored well by the Preventive Services Task Force. There have been two changes in that in the last 10 years. One was the recognition that you could identify individuals and you could make changes. And so it was made a category B, which is why Medicare decided to go ahead and pay for the CDC diabetes prevention programs. But Don's absolutely correct. One of the limitations was we didn't have hard outcome data. It's taken 15 years of the DPP to see microvascular changes, and it took 14,000 people 10 years to see macrovascular changes. And these have just come out. I think what you're going to see is increased coverage because the data are becoming available that we make a difference.
Great. This next question is for you, Sami. Is it reversal or controlled? And what's the difference?
Well, I may start, but we have real clinical and medical experts here who may need to complement my answer. Well, first I would say, unlike in cancer care, the definitions within the diabetes world are still a little bit evolving. And I think the reason is that type 2 diabetes has been seen as a chronic and progressive disease that is irreversible. And now we've been able to show that we can deliver what we call perfect glycemic control. In other words, get someone's blood sugar below the diabetes limit and eliminate the need for all diabetes-specific all diabetes-specific medications. So the question is, what do you call that when somebody's blood sugar comes down naturally below the diabetes limit and you eliminate all the diabetes-specific medications? He said remission, reversal, permanent remission. I will leave that for experts to debate. In our Verda lexicon, we use the term diabetes, type 2 diabetes reversal. Maybe Bob can add a few words there.
It is difficult. One of the problems is to prove that you have truly reversed or put something into remission, you have to take the therapy away. And we're not ready to tell people who have normalized their glucose, go back to the diet that you were on initially. That simply doesn't make any sense. So in essence, it almost becomes a semantic issue that if your glucose levels are normal, if you are not on any glucose lowering drugs, how do you define that? I call that normal glucose management.
Dr. Ratner, I'm going to go back to you here. Does reaching NGR say more about the intervention or the underlying population's ability to achieve NGR? How can we be sure it's a cause and effect relationship?
And I know precisely who asked that question. We don't know, for the simple fact that we can't do the prospective study of stratifying people by baseline islet cell function or by baseline insulin resistance. Presumably, what Lee Perot showed in the diabetes prevention program studies was that if you can get back to a compensated state, that means either lowering the insulin resistance to the point where insulin secretion can now manage it, that what you're doing is you're ultimately protecting the beta cell. And that's the presumptive mechanism. Are there underlying issues about who can reach there? Yeah, there probably are. Like in bariatric surgery, where the best predictor of normalization of glucose is short duration diabetes. The longer you've had diabetes, the less likely you are to have remission with bariatric surgery.
Great. This is a question really for anyone to answer. How can you encourage adherence in underserved communities with little access to technology, transportation, etc.? That would be adherence in general. Prescribe.
Yeah, maybe I'll start here. Well, obviously there is no silver bullet answer, which makes it very complicated. But what I can share is just from a Virta and personal experience as we've treated, whether that's U.S. veterans throughout the country or working with a number of Native American tribes. So what we've seen is one, obviously telemedicine democratizes access. So that's wonderful. You don't necessarily have to leave your house to get access to what I would argue a very good, if not world-class diabetes care, such as this Virta. So telemedicine democratizes access. So that's wonderful. Second one is the intensity of support, which can be enabled by telemedicine. Again, I mentioned earlier, we interface 2 to 3 times per day with our patients, which really is like an inpatient setting intensity. So that's one that helps with adherence. And then the third one, I would say, if you adhere to the wrong protocol, it's not very helpful. But if you do something that actually works and you receive results rapidly, such as weight loss, elimination of, sticking the drug needle into your body multiple times a day, such as insulin, those are powerful benefits, and people tend to do things that they like. So those are the 3 things that we've seen to work. And of course, there's a whole host of things to individualize to make it as easy and convenient as possible.
So I think
to that, there are some very good research building on the idea that actually text messaging is inversely related to income. People of lower income use text messaging more than people of higher income. And there are interesting innovations using text messaging for supportive care of chronic illness, and that could apply as well to diabetes. So there may be ways to counter that. This also has to do with what I called earlier the all of government approach to social determinants. If you need to think broadly about how to get the kind of access you're talking about. For example, there's a remarkable effort underway now between the National Cancer Institute and the Federal Communications Commission, the FCC, to bring broadband access to rural Kentucky, is where the experiment is, to allow for access to world-class cancer care in the most remote rural areas of a rural state. So the innovation's in order, and I do think an equity-oriented public policy arena will definitely be tackling the problem with that question is addressed that. I'm very, very optimistic though. As Sami said, this ought to lower barriers, not raise barriers in the midterm.
I hope to be able to have a firm answer to the question in 6 months. We've just initiated a trial in rural Colorado, doing a cluster randomized intervention in federally qualified health centers. These are rural areas at least 60 miles away from physician and laboratory support, but everybody has a cell phone. And so all of this is being worked through cell phones, but we're actually testing whether or not this is an appropriate and effective mechanism of reaching the rural and the underserved populations.
Well, I want to take a minute to thank everyone again. We're at 2:30. I wish we had time for more questions. These webinars always are over before you know it. But I definitely want to thank our panelists so much for joining us here today. And we will absolutely make available both the slides and the study that was mentioned for everyone post webinar. So thank you again, everyone, for joining us here today. We hope you have a wonderful rest of the day.